Welcome to the Trauma Informed Lens podcast. I'm your host, Matt Bennett. Each episode we talk about the research and practical aspects of the trauma informed movement. This podcast is not designed to replace mental health services. If you feel uncomfortable or triggered by our discussion, please consider seeking your own trauma treatment. In no way is seeking treatment an admission of weakness. It is a chance to build resiliency and experience post-traumatic growth. You can find show notes, resources, and more at traumainformedlens.org. Welcome, friends, to the Trauma Informed Lens podcast. I'm Matt. I'm back here with Denis Thompson today, and we are going to talk about trauma and pain. I came across Denis and really looking forward to bringing in your expertise around this often, I think, under talked about topic in the arena of trauma. We talk a lot about psychological pain, which I think everybody thinks of a neurobiological piece of that. But oftentimes in my history, especially working with healthcare, chronic pain as a result of psychological trauma is something that often we just label drug-seeking behavior, I think, without really understanding where that pain comes from or even understanding what that pain is. So I am really excited to have you as a guest today. So I'll give you a chance to give a more formal introduction of yourself before we jump into some good questions here.
Well, thanks, Matt. My name again is Denis Thompson. I'm the developer and creator and patent holder of a therapy called neurotherapy. Neurotherapy works on why you have the problem, not where you have the problem. So we've treated well in excess of 500,000 people all over the world, better than a 95% success rate at eliminating pain, and more important than that, eliminating atrophy, which is a byproduct of all trauma. Yeah. And over the years, we've been working in the classes, not the masses. In your area, we work with the Denver Broncos, we work with the basketball team, we work with the hockey guys, and we work with the most elite executives throughout the world. But over the last 20 years, we've kind of figured out that the way we look at pain is really upside down. Instead of thinking of it as, you know, if you turn on your television set and you look at fibromyalgia or anything else, you see that it's overexcitation of the nerve. Well, I spoke at the American Association of Pain Management years ago and upset everybody in the audience by simply saying, what if the way we look at pain is upside down? What if instead of an overexcitation, it's exactly the opposite? It's an under-excitation. And what if all of the drugs that we're using are designed to ramp down the excitation? What do you think the net result of that is going to be? Well, the net result of that is going to be 1 out of 3 people in the entire world have chronic pain. That's the net result of looking at things the way they look at things. We've treated CRPS, which is chronic regional pain syndrome. We treated probably 25, 30,000 patients, taking them completely off of medication, broke their existing neural pattern, and created a brand new pattern. Awesome. That's what we do.
Very cool. Well, boy, that right there gives us a lot to talk about.
Oh, yeah.
And maybe I'll see if you can hook me up with some tickets at some point too. But we'll save that for after the show. So, you know, boy, where do I want to go first? So what we know, let me just kind of ask you this question, and you can sort of take this to wherever, because I am not an expert on pain. I'm dangerous on the nervous system and the brain, because I think if there may be 5 or 6 people in the entire world that might be able to call them an expert on the brain because it's so complex. But you know, one of the things that we often focus on with trauma, and I'm really right now really fascinated with the sympathetic nervous system and its connection with pain. And we know that, you know, from a psychological perspective is, you know, anxiety disorders. And I'm big into right now, as the audience knows, I'm nerding out totally about heart rate variability and what that can tell us about the nervous system. And so we know that a lot of times with repeated trauma, childhood trauma, we'll see, an overactivation, whether it's the amygdala in the brain or the sympathetic nervous system and the autonomic nervous system. We'll still see overactivations of that area. And I was, in my layman's perspective of trying to tip my toe into your world with acknowledging no expertise in it whatsoever, is I've come to the, I guess, assumption more than conclusion is that overactivation might be behind a lot of the chronic pain, the terminology I hear used a lot with this. And then it would kind of set up perfectly, I think, this idea of pain as a vital sign and then opiates as a treatment of that vital sign. So, I just kind of wonder, I know I'm throwing a lot at you, but I just love for you to explore those
First off,
concepts.
opiates don't treat anything. Drugs don't treat anything. They hide things. Okay. So your assumption and your assertion that pain is a sympathetic dominant state is 100% correct. You can't have pain if you're in a parasympathetic state. It's impossible.
Fascinating.
And when you are in a sympathetic dominant state, your heart rate variability is going to be high. Mm-hmm. So heart rate variability is an excellent precursor to identifying the matrix of sympathetic dominance. There's a lot of other things. I've worked with the omega wave, which was technology from the Russians in the early 40s and 50s.
Fascinating.
But the bottom line is this. If you're stuck in sympathetic dominance, your muscles are in concentric contraction. That means that all the muscles in your body are protecting you by being in a shortened state. When a muscle is in a shortened state, it's applying pressure to a nerve. When it applies pressure to a nerve, you're going to have a net result of nerve pain. Just that simple. What I did and what I created and patented is a device that instantly takes you from sympathetic dominance to parasympathetic within a minute. So therefore, by doing that, I immediately take the muscle that's in a balled up fist and allow it to go to an open hand. And when that happens, that patient no longer has pain. I call it neurocognition. When I started 20 years ago, it was believed that your brain is hardwired and it could not change. I've been working on what we call neuroplasticity for 20 years. Every patient we've treated, we reset their neurological pattern. We created a new neuroplasticity with a new pattern where there is no pain. And it doesn't make any difference if you're a quadriplegic, a paraplegic, have spinal cord injury. Doesn't make any difference if you have a stroke. Doesn't make any difference if you have an athletic injury. Doesn't make any difference of anything. If you're in sympathetic dominance and you've had trauma, which is going to immediately put you into sympathetic dominance, you need to figure out how to get into parasympathetic. So what do? Well, we teach people how to meditate. Well, try to meditate yourself out of sympathetic dominance. Doesn't work all that well. Takes years and years and years to learn that technique. We then tried opioid. What do opioids do? What do drugs do? They basically block a signal. Does that solve a problem? No, not at all. It creates a monumental, bigger problem, and that is the addiction of the tool designed to help you. Drugs do not solve the pain problem. We've got a double-blind study going on with a couple of very prestigious universities to demonstrate we can eliminate opioids from the surgical arena completely.
Awesome.
By the way, the surgical arena is the #1 source of opioid addiction.
Yeah. So, so I guess and obviously you have patented information here, but in a way that you might feel comfortable with talking about this, how the heck do you shift from sympathetic to parasympathetic? And just for our listeners, As the expert, I'll maybe give you a little bit idea, but let's say somebody's not familiar with those terminologies. So I'd like to ask that question and maybe give us a little bit more background. When we're saying sympathetic, parasympathetic, don't have to go into too much detail, but just a little bit. And how the heck does your technology, you can give it at whatever level you want. How do you do that very quickly?
Well, first off, let's think, and everyone listening to this show needs to understand, they need to think of themselves as a computer. Mm. And every computer has two components. It has hardware and it has software. Every doctor listening to this show and every doctor your listeners have gone to are trained in how to work on hardware, including neurologists. They're not trained on the software which drives the hardware, which is the nervous system. Mm-hmm. When we say sympathetic, in layman's terms, it's fight or flight. You're afraid. Mm-hmm. So a big bear is chasing you, you're going to go into fight or flight. Yeah. If a dog is chasing you, you're going to go to fight or flight. That means that all of your energy systems are focused on doing one thing, getting the heck away from the dog or the bear that's chasing you. Yeah. That's a simple, analogous way of looking at sympathetic dominance. Now, if you've had trauma, you instantly go to sympathetic dominance. If you're anxious about something, so let's say you have Alzheimer's. Mm-hmm. Okay, everybody who has Alzheimer's, just think of yourself as losing your keys and how anxious you get trying to find your keys. And all of a sudden manifest that you've lost the ability to recognize your son or your daughter. What do you think that does for that dominant? Do you think they're in rest or recovery where they're relaxed? And no, they're in a constant state of agitation. That constant state of agitation is called fight or flight. And in medical terminology, it's called sympathetic dominance. The more than all of the doctors out there are not trained in how to change that process. Yeah. It is the most difficult thing in the world for them to do. Why? Because you're looking at it as physically. It has absolutely nothing to do with physical. It is purely an electrical signal. So what I did is I looked at it just as a purely electrical signal and said, well, wait a minute. If you're an electrical appliance and I unplug you, what happens? You stop. Mm-hmm. If I plug you back in, you start. What a novel concept that is. Yeah. So if I can change, which I can, if I can change your sympathetic dominance by simply changing the signal, then that's what happens. I just change the signal. And then I retrain your brain to stay in that new signal longer than it has been able to do before. And, we were talking earlier about, drugs being a choice. And we look at psychological pain and psychological anxiety, and we look at those folks as being receptors or desirous of drugs to offset that. Well, the reason for that is that because that's how we showed them how to solve the problem. We didn't show them any other way. Yeah. But if you show them another way, a faster way, a way that doesn't disrupt their lifestyle, gives them cognitive ability that they don't have right now, eliminates the normal symptoms of drug use, trust me, the overwhelming majority of people would choose the latter rather than the former. Yeah. That's what I do. I just change the signal.
So you got folks who, this is fascinating. So, are you, because I think the sympathetic, and I think in that there's the polyvagal theory out there and other theories that talk about the interaction between the ventral vagal and the sympathetic system. I think we make the mistake of, especially when we use, and I think you were speaking to this the right way. So I'm not saying you were doing this wrong. I just think we're, as a field, especially in the mental health arena, as we're trying to adapt, because I got no information on the nervous system either as a psychologist. I was supposed to be working with the software, but it was like, I won't even go on with that analogy.
You're not working with the software.
Yeah, exactly. And so it was like, when you think about the sympathetic nervous system, I think we because we oversimplify it because of the complexity, it's like either fight or flight or it's off. And that's where the heart rate variability, talking about the ventral vagal brake and how those systems interact with one another. So, it's not like, hey, we're either in the ventral vagal, which we know is highly connected to the prefrontal cortex, that kind of safe and social part of our autonomic nervous system, or we're in fight or flight, or if we want to drop further down, we're in our dorsal vagal, which is more of the freeze response. As you look to balance this, because that's what I love about what you're saying. It's not like we want to shut down the sympathetic nervous system or you'll die, as far as I know. So
right.
It sounds like you're strengthening the ventral vagal brake, with technology. Is that it? And like, how, like, can you tell me a little bit about how you do that? I don't want you to give away any secrets, but it's patented, so I think we're probably safe, because I know my audience will be like, "Oh, really?" You can do everything Matt's been talking about. So like how do you do that with the technology that you've developed?
Well, first off, I'm a why guy. I'm not a where guy.
Yeah.
And most medical providers are where people. That's how they're trained. They're trained on where to work because of, you tell them that you have a headache, they're going to work on your headache. You tell them you have pain in your back, they're going to work on your back. Unfortunately, that's not where the problem's coming from. Yeah. That's where the problem's ending up. So on the psychological side of it, when you look at that, okay, if you're stuck in a pattern and that pattern, you have to have a balance between sympathetic and parasympathetic. The key is a balance.
Yeah.
If one is over ramped, you have to have a mechanism to roll down the other. Yeah. But you have to keep them in balance. One without the other doesn't exist. Yeah. So they have to be in balance. How do you do that? You create a balanced pattern. Now, you've probably worked with a lot of opioid dependent people.
Yeah.
Right? You notice that if they came in limping and they were on opioids, right? Mm-hmm. And they start weaning themselves off of opioids, they still limp. They put opioids back in the system and they limp. Did the opioids stop the pattern? No, it didn't. The pattern is your brain is sending a signal to your body that says something isn't working. And if I walk normally without a limp, I'm going to have pain. What I do, and this is key, absolute key, Matt, I demonstrate to your cognitive brain you can move without pain. That's the first pattern I start to create. That physical movement pattern triggers the autonomic nervous system. And if I'm limping, I'm in sympathetic. If I'm not limping, I'm in parasympathetic.
Okay.
Then I can use a heart rate variability. And as you know, there's a thing called feel versus real. And I deal with it every day of the week. So do you. I'll get a patient. I had a patient, you'll find this fascinating. I had a patient, neurologist contacted me and said, hey, we've got this lady who has had extreme dystonia and torticollis, which means her neck is like this and she can't move and her hands are up like this for 20 years. Wow. And I said to the doctor, I said, hey, I'm a relatively active guy and relatively strong. If I stayed in this position for 20 years, do you honestly believe I have the ability to get out of that position? And he said, well, no. And he said, well, what do you think you can do? And I said, well, we'll get her out of that position. He said, you don't understand. She's been here for 20 years. I said, no, you don't understand. You ask me what I'll do, and we'll get her out of her position. He said, but how? And I said, well, let's have the patient. We'll get a Zoom conference. We'll have her family there. You'll be there. And all I want you to do is what I tell you to do. And if it hurts, you got to stop. And if there's a reaction, you have to stop. Okay. So we got behind her, put the electrodes on her. I reset her nervous system so the communication channel was working correctly. And we'll get into that in a second. And I had him grab a hold of her head. And I said, what I want you to do is I want you to start moving her head. And if it hurts, you got to stop. And if you can't move it, there's an anatomical reason you can't move it, stop. He said, I'm not going to be able to move it. I said, I know, but let's try. We got her head perfectly neutral.
Wow.
In a minute and a half. I asked the woman, what does that feel like? Now keep in mind her mother, her son-in-law are sitting right in front of her and the doctor's behind her.
Yeah.
Here's what she said, Matt. I don't feel any difference at all.
Wow.
I said, ask your doctor where your head's at. And he said, your head is perfectly erect. She said, no, it's still on my shoulder. We brought a mirror in front of her. And I said, what do you see? She said, I don't see any difference.
Fascinating.
I said to her, there's no way I can help you. She said, why? I said, because you're stuck in a pattern called feel versus real. And until you identify real versus feel, I can't help you, because that's how I break a pattern, is I break the feel versus real pattern. And she said, you're telling me my head is upright. I said, yes, ma'am. Your doctor's telling you that. Your family's telling you that. You're looking in a mirror and you can't see it. When you can see it, I can help you. And I'll keep your head in that position. You'll never know you had a problem. But until you see it, I can't change that. 45 minutes later, she called me. We went into a program. 6.5 months later, she never knew she had the problem.
Wow.
Let's talk about heart rate variability. Your patient comes to you and says to you, Matt, I'm really anxious. They're giving you every expression of anxiety.
Mm-hmm.
And their heart rate variability is 55.
Yeah.
What does that tell you?
Well, probably if they're my age, that they're very anxious, or their heart rate variability is 55 at my age, fairly regulated at my age, with the average of around 23. So
if I was anxious and I was exhibiting all of the symptoms, and my heart rate was reacting to that, and the heart rate is the key indicator, my heart rate would be somewhere around 140 to 150.
Yeah.
If it's 55, I'm stuck in that feel versus real pattern.
Gotcha.
And then what I have to say to them is, look, John or patient A, if you're as anxious as you think you are, your heart rate would be somewhere around 130 to 150. Look at where your heart rate is right now. I need to demonstrate to them reality, not feeling.
Okay.
That is a huge missing piece. Reality versus feeling.
So when you talk about this, it's fascinating. And I don't know if you've ever thought about it this way, but one of the arenas that I wouldn't claim expertise in, but I've worked around and with is, and when you say the feeling versus reality, the thing that's being brought up is folks with eating disorders and how their body image is, if you and I would look at them, we would have what, like, this person needs to eat, where they think they're fat. So when you talk about, like, with the lady who's in 45 minutes was able to see that, was she able to overcome that because you helped regulate her nervous system? Like, I'm trying to figure like how with these folks that I've dealt with who are absolutely convinced that their reality, that they, again, in their words, that they're fat. And I'm looking at them, if you don't eat, I'm worried about that you'll be alive tomorrow. Like, are you helping that shift in 45 minutes, which from a mental health perspective seems like a blink of the eye?
In that scenario, I've never worked in that scenario, but let's have an open line of communication. And remember, I'm a why guy, not a where guy.
Yeah.
Okay. So the first question is, why do they think that way?
Yeah, well, I mean, it's a lot like I think the woman that you talked about is, I think in some ways it's a mystery, but you've learned through whatever reason, probably trauma, that this is normal for me, like, and that this is fat. So that would be, that whether it's messages from society, whether it's trauma, and this is what you can control, is your caloric intake, and this gives you some sense of control, or the high you get from purging. I think, again, I don't want to simplify a complex field, but I think that there's that same thing as, I'm looking at myself in the mirror. I guess my eyes are seeing that my neck is straight, but I'm still over here. And that's, to me, that is some of the amazing thing that you accomplished in that. From the physiological perspective, you accomplished something pretty amazing. But from the psychological perspective, changing people's perception of themselves is something I think in the trauma world, because trauma gives you the message that you're a worthless person, that you're not a person of value. And, and maybe I'm comparing apples to oranges. No,
you're not. In the case of the lady, it took us 6 months before we could get her to the point where she actually saw reality.
Okay.
It took me 45 minutes to get her head into a perfectly erect state to demonstrate that it should be there, and it is there.
Gotcha.
So let's extrapolate that out to an eating disorder. And trust me, I've never worked with eating disorders. Yeah. But again, why? Why do they feel that way?
Yeah.
Okay, well, they feel that way for a certain reason. What is that reason? Well, that reason could be someone has reinforced that picture, right? So I want to change the picture.
Yeah.
Right? So in psychology, your job is to change the picture, right? Okay. What are the other exhibited symptoms that this person normally has?
Yeah, well, I mean, usually anxiety of some sort. Obviously the symptoms of the eating disorder itself, whether it's extreme calorie restriction or the binging and purging, usually, depression or anxiety, or both that go with that. Eventually, a lot of times with trauma, we'll throw a personality disorder diagnosis, which I'm not a huge fan of because of the stigma around that. So you'll see a lot of symptomatic things going on top of that, and diagnosis sometimes after diagnosis as well.
So that being said, anxiety can be tracked by heart rate variability.
Yeah.
Anxiety can be tracked by vagal stimulation. Anxiety can be tracked by basically sending a new signal to the frontal lobe. Okay. So in a situation like that, if they have physical symptoms of pain, restricted range of motion, whatever, then I would address that as part of their pattern.
Okay.
If I'm dealing with the pattern of visual, I have to give them a new visual pattern.
Yeah.
What is the new visual pattern? Well, at some point in time in their life, they were either obese or thought they were obese. But if, let's just say they've never been obese, but think they are, they need to see a picture in their mind of what normal looks like.
Yeah.
And then you reinforce that picture with my technology, and you're going to do it at roughly about 498 times faster than you can do on your own, because your brain communicates at 2 times a second and external brain communicates at 500 times a second. I'm going to get there a lot faster than you can get there.
Yeah. Fascinating.
Just by using an external device.
So one of the questions that pops up, and I think I can relate this into psychology, but I want to get, because I think, from just being introduced to your work, right. It's like, it's easy for me to be aware guy a little bit too. So if let's say you're working with an athlete, and an athlete has a severe, let's say they have a compound fracture of their leg, so they have there's nothing, there's something psychological about it, but there's an obvious injury that we would all assume would be very painful, no matter how you diagnose pain, at least originally, because something obviously is wrong with your body and that's sending signals to the brain. There is a very functional aspect of pain, whether it's psychological pain, which is kind of telling you what you're experiencing is not good, and if you can get away from it, or maybe need to fight it, that's functional, at least in the short term. And if your leg is broken, hey, your pain's telling you probably shouldn't get up and put some weight on this right now. So how do you balance? And if we can look at the athlete originally, how do you balance the functionality of pain? I guess normal pain, though I'm always cautious to use the word normal, because who knows what normal is. But how would you help that athlete? Because pain's not necessarily negative. So what is the process of working with that pain? Is it to alleviate the pain, to promote the healing process? But yeah, you don't want to, if he does something wrong with, you want him to still feel the pain, because it's going to give the body a message that, hey, how I put pressure on it in that exercise probably isn't good to continue in rehab. If I'm making any sense, how do you?
You are. There's a whole lot of common misconceptions there, but let's talk about.
Oh, great. Address them all, my friend.
Let's discuss the compound fracture of the leg, right?
Yeah.
All right. You've got a non-union in a bone. All right. So why did that happen?
Yeah.
Well, he got hit by a football player. Okay. That force delivered by that ball player should have never broke the leg. So the question is, why did it break the leg? Well, the answer is the muscles didn't get the right neurological signal to act as a shock absorber to prevent that from happening. So right away, I look at it not as a broken leg. A broken leg is nothing more than where the problem ended up. Just like anything else, ACL, MCL, PCL, LCL, quad tendon, doesn't make any difference. That's where the problem ended up. Why did it happen? It happened because the brain did not send the appropriate signal to the appropriate muscle to do the appropriate job at the appropriate time. That's simple. Now, what is pain? How does pain relate to that scenario? Well, pain is designed, and it's a byproduct of your brain to protect you. I think we're hardwired wrong. Okay. I can prove it to you over 500,000 cases, but you made the statement, and many people make the statement, and many people have that same assumption that pain is preventing us, and it's a good thing to prevent us from moving. No, it's a bad thing for preventing us from moving, because the only way you're going to get better is to move. Now, if the movement is causing the force curve to go into the fracture, that's problematic.
Yeah.
My job is to do 2 things. That compound fracture is going to take me roughly about a week and a half to resolve. It's going to take the average medical provider about 9 to 10 weeks to resolve. It's going to take me about a week and a half. I'm going to get blood into that area. The most important thing I'm going to do, other than getting blood into that area, is to take force out of the area. And I'm going to redirect that force into muscles that it should have gone to begin with to prevent that problem. Then when I do that, I'm going to have you move. And you're going to be able to move without pain because the signal that's going to the damaged tissue is no longer going to the damaged tissue. It's going to healthy muscles, and therefore there is no pain. So let's say that individual can't bend their knee beyond 90 degrees without pain, and they go to a physical therapist or occupational therapist or athletic trainer, and they're stuck at 90 degrees. Why? Because the minute they go beyond 90 degrees, they stop sending the right signal to the right muscle to do the right job at the right time. And now their brain sends a signal to say, stop. But if I then put you into the proper position, same person, same therapy, only I move the joint angle and have you do an exercise, and you have no pain. So pain is an alert signal that you're doing something wrong. You just need to do something right.
Gotcha.
Pain is designed to stop you from doing wrong things, not stop you from moving. It's designed to stop you from moving incorrectly. So let's say one of your listeners has a total joint replacement. And the doctor says, we don't want you moving beyond 90 degrees, or we don't want you moving in a no pain zone or in a pain zone. And I asked the doctor, because I go with what the doctor says, if we can put him into a position where there is no pain and it's beyond the 90 degrees, are you okay with that? He said, of course. You ask the average medical provider this question: can you speed up healing? Do you know what the answer to that question is? No.
Wow.
You ask the average medical provider, can you slow healing down? You know what the answer to that question is? Yes. So if you can slow it down, why can't you speed it up?
Yeah.
Well, you can't speed it up because there's a perceived knowledge that your body, your inherent ability of your body, can only get blood to certain areas at an effective rate to speed up or slow down the healing process. All your joints have difficult time getting blood to them, right? So when I ask that question to a medical provider, I say, if I can speed up circulation to the involved area and take force out of the involved area, will that speed up healing? The answer unequivocally is yes. The trouble is therapy doesn't do that.
Yeah.
Neurotherapy does that because it's a neural problem.
Yeah.
If you have a tendon, ligament, bone, or joint problem, you have a neurological problem, not tendon, ligament, bone, or joint.
Fascinating. So this might be a softball question to you. So, but I thought I had a good one for you, but it just might be a softball. So we know with complex, compound, chronic trauma, especially early in childhood when our nervous system's developing, I didn't do this strategically, but I think it sets it up. I often, in my sort of non-neuroscientist way, really look at the injuries done by trauma. There's biological injuries result. And I often compare it to a football player. It's like, if a football player has a compound fracture, we're going to change our expectations, at least initially, on how what we expect from the football player. And I don't even think you, with your great technology, would say, hey, we want that person to jump up and play the next play. We're going to not probably judge them for needing, at least in the short term, a wheelchair or crutches and rehab until they can get back up to maximum level of performance. And I think that's something that, instead of understanding that, approaching the impact of trauma, we don't bring the same empathy and compassion. So one way that I like to help people, especially in the helping and healing professions, but I'll talk to anybody about this because I think it needs to be out there in the public, is we see and pretty well studied more activation, actually physically larger amygdala, smaller prefrontal cortex that's active, hippocampus, smaller, less active, sympathetic, more activation, dorsal vagal and others, more active, less activation. So we see a biological injury. If I'm taking what you're saying, let's go to kind of the compound fracture of who I work with. And let's say someone who's experienced horrific, as most of them do, childhood, and then have been experiencing homelessness for 20 years. A lot of folks I work with are in that arena. So we have a neurobiology, both in many ways, I won't say devastated by trauma, because that neurobiology, that fight or flight keeps them alive if you got to live out on the street. So there's a functionality to the neurobiology that doesn't really work with the football analogy. But let's say, hey, our goal for this person who's never really had stable anything in their life is to get them into a stable housing program. So we're asking that nervous system to go from one that's been wrecked by trauma, but also well adapted to living on the street, to a quiet indoor, maybe they're the only person in an apartment, which I know like freaks a lot of folks out because it's just such a different.
I don't think it ever worked.
So it seems like your technology would also help that. You talk about neuroplasticity. You've got 40 years of trauma and a nervous system highly adaptive around that trauma. We all want that person's neuroplasticity to help them to adapt to a healthier, more stable environment. It seems like there's a lot of similarities between that change and the injury we just talked about. Am I anywhere close to?
Yeah, you are. I think the key criteria is they're in a 40-year pattern of living a certain lifestyle, and you're going to put them into a brand new lifestyle that they're not prepared to do at all.
Right.
Okay. So I'll just use a real simple analogy. You take a kid, 21 years old, who's been living in his car for 2 years, and you put him in the National Football League and give him $21 million contract, I can tell you exactly the devastation of that move.
Yeah.
Now, why? Because they're not used to that environment.
Right.
So I believe you can program them, but you can't I don't believe, and again, I don't do this. This is not my area of expertise. I don't think you can take somebody from the street and put them into a housing development and expect them to understand how to live within the confinements of that housing development, because they don't know how to do it. Absolutely. They have absolutely there's no guidebook. There's no personal adaptation helping them cope with this new environment. And it is a new environment, completely new. I just don't think it's a very good idea to do that from one devastating situation and put them into a nice situation. I think if you look at the housing projects throughout the entire United States who've done that, and you talk to the landlords who own those complexes, they'll tell you that in a very short period of time, they look like the street.
Yeah.
Why? Because that's the comfort level of that individual. I think it can be done, but I think you have to pattern. Take it one step at a time and let them see, okay, this is normal as opposed to what your normal has been. And then get them familiar with that normal and then add to that normal and just keep adding to it. It's too much.
Yeah, and I think we just to put some content, we do provide a lot of support and those things. So I don't want to just say the programs are throwing folks in without support. We got plenty of evidence that doesn't work. I think what I'm trying to get at is if you can help a football player with a compound fracture, sort of change how their neurobiology is operating, and to I guess, dramatically, according to what I'm hearing from you, speed up the healing process. Because boy, if I can get that, I've had some pretty severe injuries as an athlete. Boy, moving with pain is really difficult. So if you could allow more movement without excruciating pain, just to get me to sit in an ice bath for 5 minutes or so longer would be really nice. So I think to better frame my question is, yeah, I agree. It's not a good idea to throw someone in there without a whole lot of support helping them adapt. I just kind of wonder and this is the change that I love how the trauma research is giving us a way to do this in the neurobiology, actually putting someone in a secluded apartment, and secluded might be in a big apartment complex, but hey, if you slept outside for the last 20 years and you now have to sleep inside and it's quiet, that's an anxiety, that's a sympathetic inducing response to an already pretty devastated nervous system. And I'm just kind of wondering if the technology that helps the athlete deal with their sympathetic activation,
of course, it'll help them.
Yeah, could help them. Okay, cool.
It'll help anybody. I mean, look at what we're experiencing right now with all the anxiety.
Yeah. Oh, absolutely. That was going to be another question. Yeah.
We're addressing this pandemic. Look at the negative side effects of that. All of those side effects, every single one of them, are neurologically driven.
Mm-hmm.
Every single one of them. It's a neural pattern.
Yeah.
You disrupt the neural pattern, create a new neural pattern, you now have a new neural pattern. It's just that simple. You break a pattern, you disrupt it, create a new one, that new pattern overrides it. So think of it this way. If you, right now, let's say you have a patient and let's say they're very anxious and they are in a high sympathetic state, okay? And so we're going to say that it's like a railroad track and they have two tracks. And those two tracks are roughly about 2 inches wide.
Mm-hmm.
And their brain is focusing everything on that 2-inch wide track. I come in and I say, okay, we're going to create a new track. So we start sending a signal at 500 times a second instead of 2 times a second. And now, over a short period of time, let's say a month, we now have 2 tracks, one that's 2 inches and the other one's 2 inches. The following month, our 2-inch track is now 3 inches. That's overriding the 2-inch. It now is sending more signals. Now it goes to 4 inches. 4 inches is double what the 2 inches is. That is called neuroplasticity.
Yep, absolutely.
That's what I do.
Awesome. Okay, so I know the question on all my listeners' minds, because a lot of them, obviously, if you're working with individuals and populations experiencing severe trauma, it often leads to a range of issues. Homelessness, I mean, I find it fascinating how it basically sets up the brain for an opiate addiction. If, like I like to say, it's fertile ground for an addiction to take hold when you look at what happens to opiate receptors and this, that, and the other. And so most of my listeners, I would say, are not necessarily working with professional athletes. And I would imagine a lot of them are like, what this guy's saying, pretty cool. We could use some of that in our federally qualified health center who works with, underserved populations. So, maybe the tough question, but, how is your technology? How is your approach? Is it accessible for folks who may not have the resources like the professional football teams?
We've done this for 20 years. We've been in the cash business. Like I said, we've been primarily in I hate to use the word masses and classes, but we've been in the classes. If you could afford us, you did, right? Yeah. We now have programs where we go in and we supply a medical doctor or a psychologist, for that matter, about $200,000 worth of equipment. We supply a therapist. They see the patient. They refer into us. We're contracted with them to be their contractor. Then it's billed through the patient's insurance company, and now it's fully covered.
Okay.
We also came out with a program this year, which I'm very, very excited about. One of the reasons wanted to be on your podcast is we're going to go consumer direct. I created a mini device that is portable that anybody can use. We'll give it to them for 30 days. Awesome. No cost, no obligation. We want them to see that that tool can change their quality of life. We'll send it to them, shipping free. We'll have our staff work with them. Let's say they have pain. Let's say they have anxiety. Let's say they have breathing difficulties. Let's say all of these are neurological issues, by the way. Whatever they have, we show them how to use this tool to eliminate the need for medication and use this tool as an abortive technique and a prophylactic. Abortive means if you have pain and it's severe, you put this on, you don't have pain. It's instantaneous. It's about 1.5 to 2 minutes. You're not going to have pain. I don't care what kind of pain it is. Neuropathy, trauma, it doesn't make any difference. Okay. And now they have a tool that doesn't require them to pop a pill to mask it. They have a tool to create a new neurocognition. Now, why? Again, I said I'm a why person, right? I have no idea why we don't address. We all know the analogy. So let's say, Matt, you have a headache and it's around a 10 on a scale of 1 to 10. It's screaming at you, right? I said, Matt, do me a favor. Come over here. I'm going to put your hand on this table. I'm going to hit your hand with a hammer. You no longer have a headache. You have a handache.
Yeah.
Why? Because instantaneously that signal was greater than the signal of your brain.
Yeah.
Sending a signal to your head that says you got a headache, right?
Yeah.
That's what I do. I give your brain something else to think about and focus in on that isn't that hammer slamming on your hand.
Yeah.
Drugs can't do that.
Right.
Absolutely cannot do that. You can talk to somebody until you're blue in the face. You can do therapy on them. It is a neural signal. If I disrupt that neural signal, and I can do it with this portable device, I believe that we can help millions of people. 1 out of 3 people in the world has what's called classic chronic pain, which means they have pain for more than 7 days out of a month.
Yeah.
That's a third.
Right.
That's unbelievable. And we don't address it. We address it by medication, and we address it by what? Trying to physically help them.
Yeah.
It's not a physical problem. So I believe if we create an army of people to help other people, and we make it affordable, meaning no cost, and we give them the opportunity to help their friends, neighbors, and relatives also, and anybody who takes advantage of the offer at the end of 30 days can generate an additional small piece of revenue.
Yeah.
But they're helping people. So do good and do well is my plan for 2021 for the masses.
Awesome. Well, I love that model. And I, when you were talking about that too, it's like where trauma treatment is going. It's a wonder because obviously you'd want to kind of study this, but with things like the EMDR, with the eye movement, what we're finding, and I think it fits right aligned with your science is I never thought I'd be doing therapy where you'd follow my eye movement, or we would be doing tapping. And now in therapy, you don't even have to verbalize your trauma to the therapist. You do have to recall it, but we can work through those we can, in your language, disrupt the neural patterns and take the anxiety.
Stimuluses.
Yeah. And I'm not to throw out ideas to a man with awesome ideas, but really in many ways, if the device also, does that at a greater level, which I assume it does than the eye tracking or the tapping, wow, what a potential way, because I think speeding up the healing process with trauma, especially if we got it's not just one traumatic memory, it's a history of trauma that we need to work through, is boy, the quicker we can help people get out from under that psychological devastation, the quicker they can go on to living a life without carrying that burden around. And so whether it's physical pain or psychological pain, I'm really excited about your work, because I think it's needed in both arenas.
Well, I appreciate that, and I thank you. I mean, we work with a lot of special operators in the military, who have PTSD, all these other things. Okay, what is that? You're stuck in an image.
Yeah. Yep.
Get rid of the image.
Yeah.
But you can't do it talking about it. You can't do it with drugs. You can't do it with therapy. It is a neuro signal.
Yeah.
Disrupt the signal, change the pattern, problem solved. I know it sounds elementary. It's very complex, but the answer isn't what we've been doing. I believe the answer is change the signal.
So a quick follow. I got to ask this. I know we're running out of time, but I got to ask a quick follow up to that, because from the kind of trauma therapy perspective right now, I absolutely agree. And there's maybe an additional thing is, one of the things is to disrupt, I think, to use your language, disrupt those neuro signals and take the strength away from the traumatic memories that are leading to the disorder. The secondary part of that, though, is an integration into this, what we call in psychology, your personal narrative. So on one hand, to address the symptoms, disrupting the neural patterns is absolutely true. To experience the growth from the experience is a kind of a secondary therapeutic task in some ways. Is, you can just kind of eliminate it, but if it's not integrated into sort of your life story or personal narrative, I think we might miss that opportunity to grow from that experience and to take kind of the wisdom of and the lessons from the trauma into sort of, I like to think about, we re-enter somewhat normal, and I'll use air quotes for our listeners, normal life, but we re-enter that with a strength and a wisdom from the healing experience. So we're, I think that it's kind of, that there is still maybe that room. And I'm not saying this from, hey, I'm trying to defend my profession, but I think that the neuro part of it is that big piece of it, and to overcome the post-traumatic growth and the prison that puts so many people in. And then, like I said, I just don't want to miss the opportunity for what we call in the field post-traumatic growth, is turning that pain and wisdom into, the pain into strength and wisdom moving forward. So, I think it's more of an and than an or. So
I agree 1,000%, but I also will tell you that one without the other doesn't equal one.
And we agree on that 100% as well. So
this is a tool that you could use in your practice, put the person into a parasympathetic state.
Yeah.
Utilize your skills and your education to create that new pattern. All I'm doing is being an accelerator, allowing the signals to be receptive. Now, here's another thing that I'd like you to try sometime. I believe that every single one of your patients, and I believe every single person listening to this show, and I believe every single patient that goes to a doctor, are not neurologically efficient.
Mm-hmm.
And unless you are, and again, I want you to think of yourself as an electrical appliance. If you have a short in an electrical appliance, It doesn't work that well.
Yeah.
I believe we become neurologically inefficient by the age of 4 years old.
Wow.
Oh, yeah.
That's young. At least I can blame my parents for that then.
Well, you can blame your parents for a lot of things because there's only one neurological way to move correctly.
Yeah.
If I asked you to stand up right now and do a squat, I can tell you, even as athletic as you are, the first thing that's going to happen is your knees are going to go forward.
Yeah.
When your knees go forward, the neurological implication of that is it shuts down your posterior chain. Your glutes, your hamstrings, and your calves don't know what to do.
Yeah.
Now, why is that important? If I went into your house today and turned the main power in your house off, you're not going to be that successful at turning the lights on.
Right.
I believe one of the missing links in psychological, physiological, and occupational trauma is we're dealing with a house without correct power. So this will be an interesting experiment for you. Next 5 or 6 patients you see, have them lay down on a couch, raise their leg up about 45-degree angle, have them dorsiflex their toes so they're curled back toward the eye. You tell them to resist, and you're going to push down on their leg. If that leg does this or this, you're dealing with a house with no power. And it's going to be a long, long, long haul for you to create a new pattern.
Yeah.
However, if that is the case, and we reset that neurological flow of information, which, by the way, the first neuro pattern everyone learns how to do on their own is how to crawl. The left side drives the right side drives the left side. Most of the listeners, most of your patients are going to fail that test. When they fail that test, you've got to get that system back. You've got to reset the nervous system. And that is what our technology will allow you to do, is reset the nervous system, turn the lights back on, and now you're going to have a much more receptive audience. Keep in mind, the name of my company is ARP, which stands for Accelerated Recovery and Performance. Keyword is accelerated. Yeah. I want to accelerate the natural process. To do that, I have to make sure the power is on.
Wonderful. I think that's a great way to sort of start to wrap up. We will put information in show notes at traumainformedlens.org. But just if somebody's in their car right now, give them a little bit of how to maybe your website quickly.
Website. I'll give your listeners a special back door, which is going to give them the free 30-day use of this technology.
Awesome. Thank you.
And it's A as in Apple, R as in Robert, P as in Paul, W as in Whiskey, A as in Albert, V as in Victor, E as in Edward.com /F30.
Great.
That's it.
And we'll, if it's
I'll
okay,
give you that information. You can put it on the.
Yeah, we'll throw it in the show notes. So check it out. Give me feedback too, because I'm really interested if my users do take advantage of that. I want to hear from you about
for sure.
how this works as well. So this has been a fascinating conversation. So I feel like there's maybe a million other unasked questions, but you gave me a lot to go and digest as well, and maybe see how I squat in a mirror just to check in on that. I haven't done a squat in a while though, so I'm kind of a 46-year-old in shape dude at this point. So I'll have to check that out and see and give you some feedback. But I really appreciate it. Like I said, check out the show notes for this link, some more information. I really love how we're merging technology to improve our biology. And I think, and I like the thinking, because I'm really worried right now of, as I think healthcare, and we've got a ways to shift, but I think with COVID, this extreme kind of innovation that we're sort of seeing with some of this is, that health inequalities that exist already in our healthcare system, while the technologies are going to make a lot of us more well and live longer lives, I'm also afraid that it's going to create this gap based on the ability to afford it. So I'm so glad that you're thinking about that well, so we don't leave the folks that normally leave behind in everything we do, that we help bring the folks that need some of this the most along too. And I know listeners will be excited with that as well. So
yeah, and if they did nothing but replace their medication with this technology, they'd save money.
Worth it 100 times over. So thank you, my friend. And again, traumainformedlens.org, get all that information, and join us again next week. So thank you very much.
Thanks, Matt.